Okay. So thank you everyone for coming back after the break. This is a second portion essentially of my lecture on molecular breast imaging techniques, focusing again on the single gamma approach to molecular breast imaging, looking at some of the current status and future trends. In 2010, the United States Society of Nuclear Medicine released a clinical indications list for the molecular breast imaging techniques. And they listed out a number of indications, and I had kind of alluded to this in my earlier presentation, that they can kind of get lengthy and diluted, in my opinion. But they basically, I separated them into what really end up being two different patient groups. Again, those are patients who are diagnostic patients. These are patients who do not have a confirmed malignancy, but patients in whom we're trying to determine the need for intervention. And then in the patients who have a current diagnosis of malignancy. And they were finding that essentially they, again, from my talk this morning, that they're talking about diagnostic patients who have unresolved diagnostic dilemmas that still need to be resolved. And those are patients with equivocal exams, dense breasts with indeterminate breast abnormalities, patients with breast implants, and some kind of additional finding, discordant findings between mammography and ultrasound, and as an alternative to MRI in patients who cannot undergo an MRI study. For the cancer patients, they listed the monitor for reoccurrence, evaluation for the extent of disease, multicentricity, multifocality, and bilateral disease detection, the access of response to neoadjuvant, to assess the response of the tumor to neoadjuvant chemo, as an adjunct to a limited mammogram, whether that's a patient who has a large amount of scar tissue or some other complication limiting the utility of their mammogram. Surgical planning for residual disease as an alternate to MRI in patients who cannot have an MRI. And the patients who cannot have an MRI indication is interesting because I know in United States practice, if you ask a radiologist in the US, you say, well, how many patients can't have an MRI? And they say, oh, no one. Everybody we want to do MRI on, we can do an MRI on. And, you know, I took that really as kind of fact for a number of years. And then in one of my recent clinical trials at Cornell, we were going through the MRI indications, the patients who were listed for indications for MRI, and then the patients who actually reported. So this was done at more of the operations level of the hospital, right? The scheduling level and the operations level of the hospital versus the physician's level. And it turned out that actually, in fact, a number of patients didn't or couldn't comply with an MRI order. So there certainly are these patients, they do exist. And the primary problem for this group is that without MRI, there's a fairly limited number of additional options outside of molecular breast imaging or positron emission mammography, which can both be very helpful. This is a paper that I worked with my co-authors, was published in January of 2012 in the AJR. We looked at multi-center patient registries, so this was not a prospective study. This particular study was on clinical implementation. So these were centers that were routinely practicing molecular breast imaging as part of their diagnostic workup. These patients were referred for cause. They had a clinical indication for the disease. And we looked at 4 different centers in the United States. There was a total of 1,042 patients in the study, and overall the sensitivity was reported to be 91% and the specificity was 77%. There were 362 patients of that 1,042 who had both mammography and ultrasound available for a correlation. And the reason that the fraction is a little bit small is one of the centers in particular was from Dr. Jean Weigert up in Connecticut, and she's operating at a small regional breast center, and a lot of the patients were coming to her for the BSGIs only, so they were being sent by outside hospitals for the BSGI, and then they were returning to their home hospitals for their additional diagnostic workup. So she didn't have mammograms and ultrasounds correlative for a lot of these patients. And the BSGI sensitivity in comparison to mammography was 93%. Mammography comparison was 74%. So you'll see that's a very good agreement with the data that I showed from the Korean study. And then ultrasound sensitivity was 84%. And at the end of the day, because this is a retrospective analysis, really what was the end impact? And that was that BSGI detected 30 malignant and 7 high-risk lesions in patients who had either negative or indeterminate mammographic findings. This is that particular study and a little further review. Again, 329 patients. You can see the sensitivities here. The specificities are fairly comparable. The positive predictive values were fairly comparable as a group. And the negative predictive value, again, for BSGI was higher. So sensitivity and negative predictive values seem to be the key elements, the key advantages that were brought to this patient group by the utilization of the technology. This is a prospective analysis of 122 patients looking at the BSGI results against MRI results. And this is really a correlative study. Basically, it's showing that both the MRI and the molecular breast imaging, SESTA-MIBI technique, had essentially equivalent sensitivity. We had slightly fewer patients who were kind of lumped into this indeterminate designation, and actually, I wish I would have put it in this talk. I put it in my interactive talk for later, but I have a great example of a patient who has very broad spread adenosis throughout the breast tissue, and the the MRI is essentially uninterpretable. There's uptake everywhere, little focal abnormalities, and the molecular breast imaging technique with MIBI is very specifically positive in the malignancy itself. This particular author made some other comments that the molecular breast imaging SESTA-MIBI technique has a few other advantages. First of all, it generates only a few images versus MRI, which can generate several thousands, especially as we add the additional studies for spectroscopy and et cetera. And it can be utilized in all of the patients, including patients who have ferromagnetic implants or renal insufficiency. So those were not limitations. And that in the United States, anyway, the MIBI procedure can be conducted for a fraction of the cost of the MRI study. These are a couple of others. This is a prospective study out of Korea that was just released, and this was looking at the usefulness of the SESTA-MIBI technique as an adjunct in breast cancer patients with dense breast tissue, and they found that basically they had a pretty equivalent sensitivity, but the specificity for the nuclear medicine technique was higher. And again, that's a foundational thing. The challenge for MRI is that the gadolinium contrast that's injected for MRI is essentially a vasculature imaging contrast. And so you have this very large number of hypervascular benign conditions that'll enhance, and as well as a very nice sensitivity you can see for malignancies, but there's all these other things that show a lot of vascularity, and it really is very dependent on the reader, the experience of the reader. MRI readers who are very experienced and have a lot of time with it do better. They start to recognize the interpretation of the curves a little better than that, but it's a difficult technique at times. And this one also was out of Korea, and this was a comparison of 53 patients with BSGI and MRI, where the BSGI SESTA-MIBI technique was a little higher than the MRI, so these are fairly close, and the specificities in this group was close. And so again, I think the MRI is somewhat dependent on the interpretation. This was the management of radiodense patients with indeterminate mammograms in a comparison to the ultrasound. So these patients had radiodense mammograms with some types of findings, some inconclusive findings, and then those patients were brought into doing ultrasound and the MIBI study and prospective comparison. And in this comparison, the molecular breast imaging showed a photon sensitivity of 100%. It detected all the cancers in this group that were known. That's obviously it's not 100% in a huge population, but it was significantly higher than the sensitivity of ultrasound. And so the ultrasound in these cases missed quite a few of these malignancies, And then also the specificity of the nuclear medicine technique was higher than the ultrasound. And this isn't really surprising. You know, the huge strength, and I think all of the presenters today have done a good job of explaining this, the huge advantage to breast ultrasound is that it's a quick, it's easy, and biopsies particularly are very fundamentally easy under ultrasound guidance. And so there's a lot of good things, no radiation, these kinds of things. There's a lot of good reasons to use ultrasound. The challenge is that if you're trying to use ultrasound diagnostically over the entirety of the breast tissue, it becomes a pretty daunting task to implement it in that way. So I love the technique, but it does certainly have some limitations, as all of these do. This is BSGI in patients with a negative or indeterminate mammographic and sonographic findings and an unresolved diagnostic concern. These were 95 patients with 102 areas of concern. The KSNMMI technique changed patient management in 12% of these cases. Again, they made a note, and this particular author made a note about the low cost of the BSGI being able, one of the abilities of it to be utilized in these lower levels of indication is its lower cost. In the U.S., the MRI and the PET or PEM techniques are, well, let's throw about $1,000 or something like that. And the single gamma techniques are less expensive. And just as you start to implement these things into broad categories of practice, the strength of the single gamma technique is it can be utilized on patients with lesser and lesser incidence of disease because the cost of it's lower. So you can get kind of the same cancer yield for cost perspective. But that's certainly a moving target everywhere you go. These are patients who have suspicious or known malignancy. 159 women who had a suspicious breast lesion on physical exam or on mammography. And in this case, the BSGI identified additional malignancies in 9% of those cases. 6% of those are ipsilateral. 3% of those are contralateral. The smallest tumors detected in that study were 1.5 millimeters. The largest was 36 millimeters. And 50% of the cancers that were detected were smaller than 1 centimeter. So this is indicating that the technique is working pretty well for these smaller diseases. So what are the trends? That's kind of the general overview of the practice and what we know or what we have seen from the clinical literature in practice. What are the trends? I think the first trend, of course, is radiation dose reduction. And this is just true of all of nuclear medicine. People are looking for better ways to do these things. I'd like to start by this very interesting statement that was from the American College of Radiology and the RSNA. And they just basically are pointing out that nuclear medicine procedures have been used for more than 5 decades, and there's no known long-term adverse events for the utilization of such low doses. And so this is talking about general nuclear medicine. So we're probably being a bit oversensitive to dose, but of course we do have to pay attention to it. We always want to reduce it if we can. But you know, there's certainly no evidence that the doses that we're using now are of a big risk when they're assigned to appropriate patients. And so this is model 1. So this is a 20 millicurie injection of KSNMMI, just to kind of give you some idea of what risks are looking like. This is a BR7 age-dependent organ risk for females, administered a 20 millicurie dose at 40 years old. If you look at the modeled incidence of fatal cancers of 26% in 100,000 of women aged 40 years at exposure, that's a 0.026 incidence of a induced fatal cancer. As I showed you just briefly, one of the studies that has been done recently found 9% of the patients who had a negative mammogram, a negative or indeterminate mammogram, and a negative or indeterminate ultrasound, 9% of those patients had a malignancy detected solely by the nuclear medicine technique. So if you look at that contribution of 9% disease detection against the risk of 0.026, I think you end up coming up with something like a 450 to 1 advantage for risk to benefit ratio. And this is just a different source. This is not from the Beer 7. This is actually from the National Institutes of Health in the United States. And they estimate the lifetime risk of an individual developing cancer from a 20 millicurie dose is approximately 25. The overall in a whole population, the lifetime risk of having cancer is a 25% risk for all of us every day without exposure. The exposure of 20 millicuries of cestamide has a 0.024% risk of inducing a fatal cancer. Thus, it would increase the risk from 25 to 25.024. And again, that study about the contribution, that study about the contribution of 9% is again cited. So again, this is at 20 millicuries. And this is how it looks when it's stacked up against other diagnostic imaging techniques. So you look at the 4-view screening mammogram, and this is very important to realize. The reason that mammograms can be used on an annual basis for screening is because the radiation dose is substantially low. And that's the real strength of mammography. So this is 4-view only. This is only for the screening mammogram. Of course, the whole body radiation dose, I keep doing this, the whole body radiation dose and the dose to the breast tissue are the same because almost all of the dose, well, essentially all of the dose goes to the breast tissue in a mammogram. This is not liking me. Diagnostic mammography, however, can actually increase that radiation dose fairly significantly. When we do spot compressions and some of these other diagnostic mammograms, the radiation dose to those tissues actually goes up. So as a result, you can actually get patients, diagnostic patients who have, I'm so sorry. Let's see here. Diagnostic patients who are receiving up to about 1.3 millisieverts from the combination of screening and diagnostic mammography compared to the cestamide technique at 20 millicuries is a whole body dose of about 5.9 millisieverts. However, only 0.2 millisieverts of that is to the breast tissue. So the radiation dose to the breast tissue, even at 20 millicuries, is actually lower than mammography, which if you think it through a little bit, it makes sense. Chest CT, again, is about a 7.8 millisieverts. Coronary CT is about 10. PET at a 10 millicurie image is about 7.2 millisieverts CT. So you can see that the radiation dose at 20 millicuries even lines up fairly well with other diagnostic imaging procedures. However, these small imaging systems, these breast-specific imaging systems, are employing some new technologies and also a different geometry. And so the CZT and position-sensitive photomultiplier tubes and actually PIN photodiodes are another technology that's out there. Because of the way their systems are engineered, they have a photon sensitivity of approximately 4 times higher than a standard whole-body gamma camera. And remember that the 20 millicurie dose recommendation for cestamide was written when the cestamide was being used in conjunction with the standard gamma camera. So it should follow by reason that if we improve the photon sensitivity of the systems by a factor of 4, we should be able to decrease the injected dose by a factor of 4. The caveat in this is that according to the clinical literature, both the study that was done by Mark Williams at UVA and then our data that's being published now indicates that it's pretty hard to predict how much uptake there's going to be in a specific breast patient. So when you have 10 patients come in the door and you're injecting all of those patients with 5 millicuries, some of those patients will have a higher uptake than others. And we found that distribution is about plus and minus 33% in photon density at one standard deviation. That's a pretty broad uptake. So that means some of your patients will have very rich images where they have plenty of photons, plenty of count density, so the images are easy to interpret, and others of those patients are going to have a lower tracer uptake, a lower photon density, and be more difficult. Therefore, just in a robust protocol design, we need to kind of correct everybody up a little. If we think 5 millicuries is the minimum, we should probably go up some so that those low uptake patients still have sufficient counts when they come through the door. Actually, subsequent to this slide, the data that we're preparing now, we looked at breast density, we looked at age, we looked at cup size, we looked at a number of variety of factors to try to predict which patients will have higher uptake than others. And the only strong correlation we found actually was with patient weight. And that is obvious, right? That makes sense. If you're injecting a 220-pound patient with 5 millicuries of cestamide and a 130-pound patient with 20 millicuries of cestamide, you would expect that the distribution would change based on body size. So I think probably realistically a 6.6 millicurie dose right now is probably somewhere in the lower end. So if we look at this radiation dose again at the 6.6 millicurie level, what we see now is that the whole body dose from the technetium technique is now getting to be more in line with the diagnostic mammography, screening and diagnostic mammography, which are 1.3 millisieverts for those two studies. And now we're looking at 1.9 whole body for a 6.6 millicurie injection, and then something more like 0.06 to the breast tissue, so much lower than mammography to the breast tissue. Tissue biopsy, these have actually, there are a variety of these things under development. There's one that has received FDA approval in the United States already and CE mark in Europe, but they're all based essentially on stereotactic tactics. So the images that I'm going to show you are kind of just a foundation of how this all works. What we have here is there's a paddle that we normally use to just immobilize the breast. Again, this isn't really compression in the sense of a mammogram. It's light pressure. But you can see, for any of you who are familiar with breast MRI biopsy, there's now a tray, a grid on top, which allows you access to place biopsy needles into the breast tissue from the top. And then on the bottom there, you'll see this fairly narrow detector and a very long collimator. And that long collimator is a stereotactic collimator. It's actually two collimators that are adjoined as a single collimator. And it slides back and forth through the detector. So it slides one direction, and that gives us a 15-degree projection this way. It slides to the other direction, and we get a second image, which gives us a 15-degree projection the other way. And now we can calculate the height of that lesion from the detector, and then the distance down from the paddle to that lesion. And there's, like I said, there's a variety of ways mechanically that the different manufacturers are doing this, but they're all essentially stereotactic acquisitions. And so here's what it looks like. There's the first projection. The detector, you can see the collimator is slid to the right there. And there's a second projection. The collimator slid to the other direction. So now we have a stereotactic pair. And this is what it looks like with the patient in place. And in this case, what you're seeing there, the very small focal uptake outside of the breast, is a fiducial marker in the paddle, so we can measure how high the paddle is from the detector. And then you can see actually it's there to the left side of that breast image. There's a very, very low contrast lesion in this breast tissue. And this, unfortunately for me, was the very first patient that they recruited for our clinical trial when we were going through the FDA application process. And I had to ask the principal investigator if she was trying to kill me, because this is probably one of the more difficult ones to target. It's very low uptake. It's fairly close to the edge, but we were able to biopsy it just fine. So here's a better display of what the paddle looks like. There's these series of blocks, and into those blocks goes, into these squares goes a block, and the block has holes through it that guide the needle basically straight down from the position that it's placed into. And so you can see there's actually an alphanumeric registration system. So you say B4, and that gives, the software tells you B4 hole 9, and it gives you an idea of which of the holes to place the needle into. And then the software also gives you a height, so you know how far down to go from the paddle to take the biopsy sample. One of the keys that we needed to figure out, and the PEM people have found the same thing, is when you push a needle down into the breast tissue, you can do what's called snow plowing or pushing it. You can actually, instead of cutting through the tumor, with the needle. In some cases, what you actually do is you push the needle down, and the tumor, because it's hard, shifts down with the needle. So it's not actually going to sample the tumor. It's going to sample, it pushes the tumor out of the way. So you need some method so that you can see where the sample is going to be taken and where the tumor is before you take that sample. And the way that all of us have approached this is we've created some type of a radioactive sleeve, radioactive source. So there's a very small point source at the end of that stainless steel obturator. And then there's a sterile sleeve that goes over the outside of that so we can use it. So the sterile sleeve, of course, is per patient, and the source itself remains in the center for about 6 months. And the key to this is that once we've figured out where the lesion is in the breast, we can actually slide the collimator to a position where we're acquiring one planar image from two different projections. Because those projections, you can see the red and yellow lines, those two fields of view for those two collimators actually overlap. And so we can take only one acquisition and we can know the position of the lesion and the position of the source. And that's what this looks like. So you can see that low contrast lesion there on the left, very low contrast lesion, very near the blue and the red lines. But that's a single acquisition giving you two views of the image, of the lesion. And then the second image is that same patient with the radioactive source in place, the point source in place. So now we can see that the source and the tumor are in the same location, and we know we're safe to take the biopsy. Trend 3, I think, people are trying always to improve, to move beyond planar, to move beyond the way we visualize images. And so probably trend 3 is really an image acquisition and display. And I was actually, my group very strongly, we bought on very well to this idea of dual opposed detector technologies, where you can fuse the images. And we thought, okay, well, if you fuse the images taken opposed from the breast tissue, we could increase tumor sensitivity. If we fuse the images together, we could reduce either the dose or the time. Not both by any large degree, but you could reduce one or the other. Probably by a factor, by a half. But the thing that we found out when we went to clinically implement this idea was that because patients can have a heterogeneity of uptake in the breast tissue on sestamibi, when you take image 1 and image 2 and you fuse them together, you basically magnify that heterogeneous uptake, and it can make some of the cases relatively difficult to interpret. So we thought it was a great idea. And I think it still may have some place, but there's certainly things that need to be worked out. And this is just a series of a couple of different systems that have been compared. And I think that there's not really appearing to be a strong correlation between single head or dual head and sensitivity in terms of detecting breast malignancy, is basically what we're seeing so far. The second area that we're working on, and this is really important area for patients where we're doing neoadjuvant chemotherapy work. If you give 10 different technologists the same image and they draw regions of interest, we all know that you'll get 10 answers that are close but not exactly the same. And so if we're trying to quantify the tumor response or we're trying to quantify tumor uptake, this is a visual quantification work that we have now. So the way the software works is it takes that whole breast and it draws basically a skin line. So it knows where the breast tissue is. It calculates a mean value for the area of the breast, and then it does a high-frequency uptake search to determine where the focal intensities are. And then immediately around that focal intensity, it draws out in a radial pattern until that focal intensity drops below relatively close to the standard deviation. And when you do that, that's what it looks like. So now we have basically a colorization palette that can tell us that the primary tumor is 1.38 above background, and the node there is about 0.69 above background. And so we have a value that we can assess. The importance of that value is that if this patient comes back after neoadjuvant chemo, the software does it exactly the same way, and it gives you another number. So it's a way to standardize this uptake rather than doing it by ROIs. This is our terrible looking monster. It's a really an interesting device, but unfortunately, like most research devices, it doesn't look super nice. This is actually a combined tomographic X-ray and limited angle SPECT system. So what you'll see here is you'll see this is the X-ray tube, and then the digital X-ray detector is down below, and then this is a gamma camera right here that's mounted on posts, so the gamma camera can slide back out of the field of view, and the CT rotates one direction, and it does a limited angle tomography in one direction, and then the gamma camera comes out and it does the limited angle gamma imaging in the opposite sweep. And so you get these kind of very fused images, and there's a lot of details that no one except nerds care about. And it didn't start automatically. Let's see if we can get this to play.
1 more minute, Dr. Keeper.
Yeah, this is the last slide. It doesn't want to play. Oh, this is why I like to use my computer when I can. I apologize. If this was playing, what you see actually is the mammo-only tomo slicing through the breast tissue, and then the fusion of the mammo and the MIBI scan slicing through the breast tissue. And this lesion becomes very evident as to which planes that lesion is located in. And thank you very much for your attention.